And Elaine, you mentioned this earlier about there are medications that would want to be avoided for Dravet syndrome. Are there others that we should worry about? I mean, you mentioned the sodium channel drugs, but any other ones that you'd want to avoid for Dravet?
I think that the evidence there is most for the sodium channel agents. There also has been some concern using phenobarbital in kids with status epilepticus and Dravet. I think you have to use that with caution. Everything has a balance and a risk, but I think importantly what we really want to avoid are those sodium channel agents. Interestingly, in adults though, there have been some cases where lamotrigine can potentially benefit adult patients with Dravet syndrome. So I think what I would caution people, if you have an adult in your practice with Dravet who seems to be responding well to lamotrigine, I think that you really need to kind of consider that. There are exceptions all the time. So, but certainly I think the rule in kids is to not use oxcarbazepine, phenytoin, at least prophylactically. I think we can probably use that in cases of status. Carbamazepine and lamotrigine, those probably should not be used prophylactically in kids with Dravet.
Well, and you mentioned status epilepticus. I think that's an important concept that we should talk about. What should we use as far as treatment for a child coming into the emergency department in status epilepticus for Dravet?
Yeah, so I think the important thing there is making sure, and that goes with Lennox-Gastaut as well, these kids are going to have breakthrough seizures. They are going to have seizure emergencies. Families need to know that, and they need to have a rescue plan. And a medication they can actually implement and give to the child in the home. For many of our kids with Dravet syndrome, what we will have families use initially is a benzodiazepine, whether that be diazepam, whether that be midazolam. It probably doesn't make a big difference, but you want to give that child a medication that is dose appropriate for their weight. For kids with Dravet syndrome who have the recurrent predisposition towards prolonged seizures, we actually often tell our caregivers to give that medication immediately. If that child goes into a convulsive seizure, do not wait the 5 minutes, because many of these kids are going to go longer than 5 minutes all the time, and you're just sort of waiting, and I think you have a better success if you give it earlier. These kids also need very carefully derived seizure rescue plans, and those are really individualized. I think we did a survey of a number of pediatric neurologists a few years ago, and I think what people agreed on were benzodiazepines, and that's kind of where the agreement ended. Do people give levetiracetam next? Do they give valproate next? What do they give next? There was a lot less agreement there, and so I think what's really important is to figure out with your neurologist what medication works best in that situation. And for some kids, we've used really weird protocols. Like I have one child who gets propofol, a single dose of propofol, because nothing else works, and that's what they get when they come into the ER. It's not an infusion, so we don't have to worry so much about propofol infusion syndrome, but that's what works for them. And so really kind of individualizing that rescue plan.
Well, and Ian, Elaine mentions the rescue plan, and how do you address the rescue plans? Do you have a document that you hand to your families, or how's that handled in your practice?
Yeah, I would echo exactly what Elaine said in terms of needing a personalized, customized rescue plan for each child. I recently, had some confusion in the school system where we had given kind of a tailored plan, and the school had rules against giving 2 doses of Diastat, for example, one after the other. So those kinds of things come up, and you just have to kind of work through them, and if it's necessary for the kid, it needs to be followed. But I would echo what she said in terms of wanting to make sure that the intervention is as early as possible. I think it's less a matter of 5 minutes or not. It's more of a matter of what's their typical bell curve. How often do they have seizures that exceed a certain amount? And once you've tripped past that certain amount, then you want to institute the rescue medication. So thankfully, we're having more and more treatments that are being investigated. We're having inhaled benzodiazepines. We're having medications that are way more dissolvable, such as the clobazam. They had the 3D printed levetiracetam that I've used with variable success in kids. And you want to remember that the oral route is still available in kids that are postictal and a little bit sleepy but able to swallow, if you have a dissolvable medication and you're able to give them a bolus dose of one of their home medications. So very customized.
No, I was just going to add your question about giving a printed protocol. I actually think that's extremely important because these kids are very complicated. I agree completely. It's very individualized per patient. And the reason I think the printed protocol the family has is important is because many of my kids will go initially to an emergency room where there might not be a pediatrician or a pediatrician who doesn't know how to manage out kind of status other than the ordinary status. And I think it also gives the families a degree of comfort to know that when they go to the hospital, you know, they don't have to worry that the physicians aren't going to listen to them about what they think is best for their child, but they can show the protocol that we have come up with. So I think that's really important, honestly, in any kid with refractory epilepsy.
Yeah, I agree completely.
I'll add just a little bit because I love education and seizure protocols. And I always quoted that for people with epilepsy, the most common emergency you will face is a seizure. It's not a fire by statistics, but we do fire drills, and I encourage that to be done. But for epilepsy, you almost have to have the family, just like our clinics, do a seizure drill. And every epileptic should have a seizure plan. Of course, Lennox-Gastaut and Dravet is one notch higher. You have to have the seizure plan plus the emergency room care, what to do for the status epilepticus. But the only way that you can be prepared for an emergency is having a plan. So you have to print those plans as simple as you can so that they can, and try to do a drill.
Well, you know, that takes me back because if you remember when I was your resident, we started that program with your printout. You had a nice little phrase and that we typed out and started to hand out routinely. And you know, that wasn't that long ago and it was so foreign, and we still really haven't overcome that barrier. I think many of our patients don't have these plans, and another area of improvement. So it's great that we talked about it today.
And one thing that I think can be useful is telling the parents to report the contraindicated medications as allergies, right?
Yes.
When you're in the emergency room, they're always going to ask you what your allergies are, and it's way cleaner and you know, hopefully not dishonest to just tell the people who are providing your care that you're allergic to phenytoin, oxcarbazepine, carbamazepine, and lamotrigine, so that you just don't have to get into a long discussion about the details of your epilepsy, et cetera, but they'll not be given.
You know, we try to put that actually on our seizure action plan and also in our electronic health record in the allergy banner for that exact same reason. And I think it works well. It's important.